So far as predictors variable are concerned, we try to understand the socio-demographic variations in these exposure variables. So we have included a series of uh, individual and household and community level variables, like the women's herself years of schooling, her mass media exposure, how many number of surviving children she has. Then of course at the household level we have used religion, caste, and for some of those household size, wealth quintile, place of residence, and region. We know India is a very vast country, so to understand the regional variations, we have kept region as one of the variable also. So far as analysis is concerned, we have done a descriptive, bivariate, and binary logistic regression to understand the adjusted odds effects of these socio-demographic predictors on our outcome variables. So before doing our before finalizing the variables for our analysis, we have checked the multicollinearity among the predictor variables, which is essential. I hope all of you will agree with me. So using the VI method, so we check the multicollinearity among the predictors variables, and then we finalize that which variables we will be including in our final analysis. So coming briefly to some of the results, we did not find much variation so far as socio-demographic variation in our bivariate analysis, but only in case of exposure to family planning and informed modern spacing contraceptive choice, there was minor variations by the variables called years of schooling, mass media exposure, wealth quintile, and region. As you can see, there are variations, but I am not going to explain this in detail because I am going to spend more time on the subsequent slides, which talks about the more robust analysis, because these are based on these results. These forest plot presents what are the or presents the adjusted odds ratio of the predictors of exposure to family planning measures. As you can see, compared to those women who have never gone to school or never had schooling, those who are with 10 or more years of schooling, they are significantly more likely to expose to family planning measures. And you can see also there is strong regional variations compared to the women from south. Those who are from the north and central and east and northeast, they are more likely to expose to family planning messages. Similar, this is the adjusted odds ratio for informed contraceptive choice. You can see it is much better compared to south. It's not better in other many places like east and northeast. And this is the adjusted odds ratio of autonomy in contraceptive decision making. You can see education playing a major role, and of course that regional variation is there, and those who are exposed to family planning methods definitely are better likely to have a involved in contraceptive decision making. I am ready to discuss if any conclusion, but in conclusion I would like to say the adolescent women's exposure to family planning methods is not universal, and of course their access to or informed contraceptive choice is also not adequate. So this is the conclusion. I would like to say that there is wide regional variation. So we hope there are several existing policies to enhance the SRH of adolescent women in our country. So strengthening those things, especially targeting those socio-economically vulnerable women, will definitely enhance the adolescent women's access and especially right to contraception. Thank you. Thank you all.
Distinguished panel of co-chairs and my dear colleagues. So if you talk to any parent, a teacher, or a healthcare person who work with adolescents in Sri Lanka or in elsewhere, South Asia, they will tell you one of the toughest tasks is to work with adolescents and youth. And if you look at the problems that they face and the spectrum of health issues that they are now living with, changing so fast due to various determinants. According to the 2007 World Development Report, 60% of the non-communicable disease risk factors are accumulated before the age of 20. So dealing with adolescents and addressing their health problems by changing their norms is something that most of our healthcare workers are looking at. But if you talk to healthcare workers, one of the main problems that they always come up with is that how to engage with youth, how to change their norms, how to address their attitudes, and finally how to change their behavior. So this particular research that we carried out as a part of our main research, just to test out a model to using health promotion principles to identify ways of changing norms of adolescents in order to change their behavior. So this was carried out in Anuradhapura, and these are my fellow researchers. So if you look at the situation of adolescents in Sri Lanka, the demographic features are very similar in Anuradhapura compared to the Sri Lankan situation as well. And the problems that they face change so fast. I would like to highlight only one information here. According to the 2019 Ministry of Health report, 12% of the newly diagnosed HIV cases were from this age group. So this is one important factor which denotes how their sexual and reproductive health behavior is changing. With regard to youth and adolescents, we know it's a challenging period, especially in relation to sexual and reproductive health, because they are sexually active, childbearing, and also there are various demands like out-of-school compulsory, out-of-school children, unmarried, and also being sexually active. Dealing with SRH with adolescent is something we found is very important. Now, why we use health promotion intervention? Because similar research done in elsewhere, the inherent property of health promotion to actively engage people and to allow them to take control of the factors which have an impact on their well-being was found to be very effective. That is one of the reasons why we use health promotion. And the objective was to identify and address norms related to sexual and reproductive health among youth in order to promote positive sexual and reproductive health outcomes. And the methodology, the study design was a course experimental study because we didn't want to do a randomization, because we took one setting just to test out this model. And study setting was Technical College Anuradhapura with a control group where the Technical College Polonnaruwa were used as the control group. And we took study participants as the young people between the age group of 18 to 25 are registered for at least 1 or 2 year courses, all are unmarried. But there are students who are doing short courses where we not included because we can't follow up them. And the pre-intervention, we collected information using 2 tools, the self-administered questionnaire, just to collect information on the norms, attitudes, knowledge, and their practices to a certain degree, and the focus group discussions used to get an in-depth view of their norms and their attitudes on the sexual and reproductive health practices. And based on that, using health promotion principles, we designed a health promotion intervention. Initially, the model was developed based on literature, and then the model amended after meeting a group of students at the technical college in order to identify a model which really suits them according to their context. And that model was finalized. Now, if you look at the health promotion intervention, there are several phases of this health promotion intervention. The first phase is initiating this process and identifying a collective goal with them, and then, understanding and prioritizing the determinants that influence norms related to SRH, and identifying the effective actions to change the prioritized determinants by this youth group, and finally, monitoring and modifying this process by giving inputs using a facilitator who's capable of health promotion and continuing this implementation of various actions to address these determinants. Now, the process was initiated with this group by dividing them into 7 groups, and they allowed to meet physically as well as, they could communicate with the social media platforms because, the youth, they're very active in social media, and then identified a collective goal and the problems that they wanted to address. And also during that time, we tried to identify some of the norms that is prevailing among them. Then the determinants, during this phase, we use several simple tools to identify the list of determinants that they think are the ones which control their norms related to SRH. And finally, some of these determinants are prioritized. So 3 major determinants are finally identified, which they found to be impacting on the norms of SRH. 1, negative media influences, gender stereotyping, and lack of knowledge on SRH and various myths related to SRH. And the monitoring and modifying this process continued during a period of 6 months after initiating this process with the help of a facilitator. So implemented actions were mainly focusing on addressing these determinants. And you can see some of the actions carried out by students. I want to highlight this. All these actions were mutually developed with the youth. By actively engaging them, the facilitator gave some inputs for them. So interactive discussions were conducted and also tried to understand the prevailing norms. And during these conversations, the facilitator tried to improve their knowledge and also allowed them to identify ways and means of looking for the right knowledge and share this knowledge using the social media platforms and various tools, simple tools developed by them to share this knowledge. And the media influence, they worked with Facebook, they developed video clips and various dramas among them to educate the fellow colleagues how the media influences norms, especially with regard to SRH. And also they found, they developed various activities like special dates to talk about SRH, and they developed various materials by themselves to share in WhatsApp and Facebook. And this is one way of empowering their capacity to address gender norms and SRH norms. Then finally, the data were collected after the intervention using the same tools. The analysis was done, the quantitative data analyzed using descriptive statistics and analytical statistics. Qualitative data thematically analyzed, comparing pre and post of only the intervention group. And ethics approval was taken from the Ethics Review Committee of the Faculty of Applied Sciences, Rajat University of Sri Lanka. And the permission was taken from the director and principals of both technical colleges. And consent was taken appropriately, and anonymity and confidentiality was highly protected. And if you look at the results, these intervention group and control group, they were predominantly in the age group of 2022 and female in nature and, currently having some kind of an affair but unmarried. And if you look at the results on knowledge on anatomy and physiology of reproductive system has significantly improved, and awareness on different contraceptive methods improved after the intervention, even though the knowledge or the awareness increase is not the main part of the intervention. You can see even the most uncommon contraceptive methods, the knowledge on uncommon contraceptive methods was significantly improved. And the most important part is here, the norms related to SRH. Now, such as, I believe that getting pregnant before 18 years is okay if they're married. So that kind of norms were significantly changed during after the intervention. So initially, the number who agreed and disagreed with these statements significantly changed after the intervention. So these are some of the statements. If a girl suggested using condoms to her partner, it would mean that she didn't trust him. So initially, that some, to a certain degree, nearly 50% believed that yes, but then most of them strongly disagreed with these norms. And these are some of the other norms, such as girls should obey the decision of the boy without argument to maintain a relationship. Earlier they thought yes, but later most of them disagreed with such norms. And using condoms reduce sexual pleasure. Initially they thought yes, and after the intervention we found in the intervention group mostly they believed no. And using contraceptive methods during sexual intercourse, this is something that I want to highlight. There was a group, like 17 members were having, even though they are unmarried in this age group, but they were having intercourse or sexual relationship. There is, you can see the improvement in using contraceptive devices during their intercourse. So my conclusion is that you can see this intervention to a certain degree helped youth and adolescents to actively engage in a process to improve their knowledge as well as their norms in relation to sexual and reproductive health by addressing some powerful determinants which shaped their norms.
I would like to thank organizing committee as well as AFPI Sri Lanka as well as IPPF and then the co-chair also for accommodating me to present some of my findings. So, I trust everyone will support me that teenage is a fragile group, and then we have to handle very carefully. And morning also we have seen that Dr. Iqbal quoted some DG WHO, and that is a very important future group, and we need to give full attention to this group. So having this in mind, my topic says, like, effect of consanguineous marriage, child marriage and teenage pregnancy on pregnancy outcome. It's evidence from India. Like Dr. Manas, I am also using the NFHS yeah NFHS 5. This is my objective. How this consanguineous marriage and child marriage and teenage pregnancy, which is contributing negatively to the delivery outcomes. So everyone knows that consanguineous marriage is also having many research studies shows that it has a negative impact on their child, maybe having the deformities while by birth, as well as child marriage. It's prevailing in most probably in Asia, South Asia, and especially in our India also we have child marriage, that is as per government rule less than 18 years of age. And then the teenage pregnancy. The moment they marry, the coital frequency is more, and then they tend to have the teenage pregnancy because they do not have more information how to use the condom or preventive measures, so they tend to have that pregnancy. So that's why all this consanguineous marriage also negatively impacting, as well as a child marriage and then the teenage pregnancy. Definitely it is going to affect our delivery outcome. Maybe it's a first delivery or even the consecutive deliveries also. So as I said, I am using the NFHS file like Dr. Manas, and then in my study sample size is 5,462, and you can observe this thing, my focus is a 15 to 19 group, but NFHS 5 has 15 to 49. It's 7 lakh plus sample size, but I reduced and then filtered for my understanding my analysis. It comes around 5,000 plus. So what I did, I have to understand how this consanguineous marriage, child marriage, teenage, how they are correlating each other. So there are some couple of questions related to this consanguineous and child marriage, teenage marriage, and then I have dichotomized these variables into, for my convenience purpose, 0 and 1, and then I try to implement our chi-square method to understand the association between these variables, and how it is going to affect child loss. And then I used univariate, bivariate, bivariate logit regression. And here you can see what happens without no schooling. It's impacting their childbearing, because without any education, I think they tend to have coital frequency more, as well as the childbearing in the early ages, which is going to disturb their whole health thing. And then it's more in scheduled tribe also, like 9% in my study, and with the combination of consanguineous child marriage, teenage marriage, it's affecting their first child. And then I have taken not only the first child, I have taken the first, second, third child also, because you will be amazing that 15 to 19 we have some proportion. In the coming slide you can see very good proportion. They have the 3 TFR also, CEB. Couple of graphs, you can understand the demographic distribution within my context. You see the 19 years is more than around 60% they are in the 19th group, but they might have given birth early, before 18 years also. So that it is going to affect in my study, as well as the other demographic variables. These are the demographic variable, like type of residence. I have taken child marriage, yes or no, and then there is a, for consanguineous marriage, where there is a couple of question, and then I have clubbed into first cousin. It's a very close relative, as well as the other blood relatives also, and then the blood relatives. And you can see the child loss also. Yeah, you can see here 1.2%. It is very few, but when you see the sample sizes of 5,000 plus, they are giving 3 children before attaining the 19 years. So which is very alarming picture. As well as we have the wealth quintile, most of them falls under poorer and then the poorest. Next. I thought, okay, this will correlate significantly, and sometimes it doesn't work. It could be various reasons. So what I observed, child loss with the child marriage, it is not significantly correlating. Like you can see the chi-square value, and then which is the p-value is more than 0.05. Whereas child loss and consanguineous marriage, its association is very high, as well as it's a significantly there is a correlation. Next slide. Yeah, but the education, again, it's not significantly correlating. But the age at the first birth, they might have married 15 years, and then immediately they might have given birth also. So that the age at marriage also is very correlating significantly. Yeah, see here what happens when we do the logistic regression. We have the omnibus test, which shows high significant. Yeah, thank you. Highly significant, the model has the significant to the child loss, and the variation between the 0.5 to 1.8 variation. And then the accuracy classification, we have the classification table where we got the PAC as a 96%, which is very good. And then the Hosmer-Lamshaw test shows the insignificant, which is very important. It should not be a significant one, it should be insignificant, so that your model is best fitted. And these are the 3 things, like child marriage, married after those who are married after 18 years will have 1.2 times the chances of having child alive than the other group. And similarly, the next one is the consanguineous marriage. When the women have married a person, the first or other blood relatives have a chances of having the child dead than the other group, like non-blood relative marriage. And the same, and the another thing is that women who have had child before 18 years have lesser chance to have the first live birth. It definitely it is going to be a kind of a child loss. Next one. So what happened? We have to give more education on about the consanguineous marriage, as well as the child marriage, as well as the teenage pregnancy. They are very difficult to handle, and then we have to give the more awareness to give all these meaningful points. And then we have to reduce our poverty, as well as the education we have to give, so that they will drag their years concentrating on education, and then the onset of age at marriage will be higher, so that everything will be reduced. So these are the recommendations. Actually, we have the government law, but the implementation will be a difficult thing. So we have to have a kind of monitoring well, and then we have to implement this thing in the proper way, so that the age at marriage should be beyond 18 plus for female. And in India, everybody knows, many people may know that Gauna is there, so that also should be avoided, so that the teenage child marriage will be avoided.
Very good afternoon. And this is about an evaluation we did about an edutainment program on sexual and reproductive health promotion delivered to adolescent school children called Rhythm to Life. So you might wonder what is about this edutainment. So it's kind of a education plus entertainment. So I'm Amila Chandrasiri, and I'm presenting this on behalf of my team. And so promoting sexual and reproductive health among adolescents through innovative and effective interventions has emerged as a priority need, because as a country, we have been facing serious issues related to reproductive and sexual and reproductive health in this age group. Though several awareness programs has been implemented in Sri Lanka by many organizations and many partners, the expected outcome has not been achieved due to poor reception by students and the lack of integration with the existing public health networks, because programs are doing haphazardly ad hoc programs and there is no integration. So we thought of these issues in designing our program. And this Rhythm to Life was developed by a team led by a public health specialist as an edutainment program to deliver key SRH messages to adolescents through an innovative approach. So we strategically didn't use any word like sexual, reproductive health, anything. So we put the title as Rhythm to Life. And the program was designed as a music-based edutainment program which delivered through storytelling model. So that means it was not a lesson. I mean, it was not a formal lecture. So it was a kind of a story, engaging with the audience. And the main target audience was grade 9 to 10 children. Why we choose this group? Because according to the data and evidence, for teenage pregnancies and risky sexual behaviors, this is the most vulnerable age group at the moment in the country. So this program consists of 4 to 5 segments, where each segment focuses on particular objective or topic. Relationship, we start with relationship skills, and then strengthening parent-child bond. And we also talk about saying no to drugs and violence and other 2 serious issues faced by adolescents. And then the most important topic, understanding physical and psychological changes related to puberty and age-appropriate sexual and reproductive education. And the content was developed based on age and culturally appropriated SRH content in the 10 life skills introduced by National Adolescent Health Program. And by the Ministry of Health, a special package has been introduced called 10 life skills. So it is about strengthening life skills to say no to risky behaviors and promote positive behaviors. So we strongly believe as public health specialists that for SRH issues, strengthening life skills should be the first answer. That should be the, that is where we should focus on. And 1 to 2 popular youth loving songs are played in each segment to supplement the flow of discussion. After each program, a system is established and promoted in the school to confidentially forward SRH issues and problems to the counseling teacher. In Sri Lankan schools, there's a designated counseling teacher in more than 90% of schools. And so this was not a one-off program, we go and we do the program and come back. In every program, after every program, we get the principal and we get the counseling teacher and we have a discussion. So we, during the program, there's a one segment, we promote help-seeking behavior. And in the meantime, we encourage the counseling teacher to keep a box in front of her office, because if a child is hesitate to come and speak, can write a note and put that to the box. And we also encourage, if teacher likes, to introduce a WhatsApp number where children can send their problems. And then a response system was also initiated while connecting to the counseling teacher to external support networks. And we have a well dispersed system called adolescent health clinics across the country, run by every MOH. So the first line of help is counseling teacher, and we advocated counseling teacher. If you can't handle the problem, refer the issue, refer the child to the adolescent health clinic happening every Saturday in the nearest MOH office. So usually we also invite the area MOH and the area public health inspector. Public health inspector is the key public health worker who delivers school health activities in Sri Lanka. So we invited both of them for our programs. And so far we have conducted more than 50 programs across southern and western provinces of the Sri Lanka, covering nearly 25,000 students. But for this evaluation, we particularly took few programs, and 2 evaluation criteria were used. And you know that there are 6 evaluation criteria in the OECD framework, but we only choose relevance and acceptance. An evaluation questionnaire was designed and distributed to participants after each session. The quantitative section consisted of 5 items which assess the acceptance and relevance, while responses given to qualitative sections were used to further elaborate these 2 criteria. An open-ended question were asked at the end, asked them to write few lines about how they perceive the program. And 3 programs conducted during the first phase were taken for the evaluation. 1 urban boys school, 1 urban girls school, and semi-urban mixed school. And descriptive analysis was done for the responses given for the quantitative section, while qualitative information was subjected to thematic analysis. So this is a few glimpses of our program. See the joy and happiness and how they been cheered up. And active engagement, we always engage students. And this is what in the program we at one segment we ask them to identify your career dream and go home and write it and place that where you spend most of your time at home.
Hello, thank you for attending this presentation. Today I will be talking about a systematic review that me and my research team had done, looking at the sexual and reproductive health, information and service needs and preferences of young people in Sri Lanka. So my name is Madhavi Veerasingham and I'm a PhD student under the Monash University School of Public Health and Preventative Medicine, particularly in the Department of Global and Women's Health. The systematic review I'll be talking about today was completed as a part of my PhD project, and this study was undertaken with the expert guidance and supervision of a research team including Ms. Chetana Muduna, Professor Jane Fisher, Dr. Shelley McCliffe, Dr. Jagari Sastry, Dr. Neelamani Hevagigana, Mr. Karan Vashni, and Ms. Lorena Romero. So the systematic review we did aimed to synthesize and analyze the evidence on the sexual and reproductive health, information and service needs and preferences of young people in Sri Lanka by looking through secondary published data. So to do this, we collected data for this study. We conducted electronic searches across 4 databases, which were online, including Ovid Medline, Embase, Global Health, and PsycInfo. We developed a search strategy using a combination of subject headings and free text terms focused on 4 domains. So these included location and population, which was young people in Sri Lanka, so aged between 10 to 24 years. Topic of research, which was sexual and reproductive health topics, which we identified through a pre-real literature review. And key outcomes, which was relating to information, service needs, and preferences. These searches were adapted and appropriate appropriate to specifications of each of the 4 databases used in the study and was run at the beginning of January 2024. So the references used in this study were from the beginning of, we identified at the beginning of this year. The reference list, after this, the reference list of the articles included in the systematic review were hand-searched and cross-checked to identify any relevant studies not captured through the database search. Citations were retrieved from searches and uploaded into Covidence when the title and abstract were screened for eligibility for data extraction from the research team, by the research team, and this was done according to the inclusion and exclusion criteria which has been detailed on this slide. Following this, we extracted data on the research design, participant characteristics, and key findings from all studies which had progressed to the data extraction stage. Furthermore, we assessed the quality of studies which were included in the systematic review using the KMEC quality assessment guidelines. So the database search identified a total of 1,210 articles. After applying the exclusion criteria, data was finally extracted and analyzed from 16 studies which were included in this review. In total, quantitative data was collected from around 19,531, and qualitative data was collected from 32 young women and men. Furthermore, there were 13 quantitative studies, 1 qualitative study, and 2 mixed method studies included in the review. Studies were conducted across urban and rural Sri Lanka. However, there was a lack of ethnic diversity in study participants, as all but 1 study had a clear Sinhalese majority. The topics which were researched included sexual health, reproductive health, pregnancy, and menstrual health. Due to heterogeneity among studies in areas such as sexual and reproductive health topic researched, the data collection tools used, and the interpretation of key findings, a meta-analysis was not possible. As a result, we carried out a hybrid inductive and deductive thematic analysis to synthesize qualitative and quantitative findings. According to this analysis framework, we identified themes in the wider literature which was noted in a codebook and used as guidelines to deductively code, analyze, and organize data extracted from studies. Furthermore, while coding, we found new concepts and ideas which emerged from the extracted systematic review data, and we added these themes which were developed inductively to the codebook as well. We used this final codebook to analyze all data. So I'll just now move on to the results. So when looking at the sexual and reproductive health information and service needs and preferences of young people in Sri Lanka, we found that young women are more likely to seek out information compared to young men. However, both young women and men preferred to receive information and care from informal sources such as their parents, particularly their mothers, as well as their peers. They were less likely to use formal and more reliable information sources and services such as healthcare providers and schools or teachers. So mothers were a vital source of information for young women, particularly on topics relating to the development aspects of their reproductive health. For example, we found that when young men experience their menarche, they usually turn to their mother for advice on menstrual hygiene and pain management. However, when it came to their sexual health and discussing topics such as contraception, young women were most reluctant to go to their mothers for information as they feared they would be misunderstood or judged. On the other hand, both young women and men frequently turned to their peers for general information on topics considered to be more socially taboo, which they were reluctant to discuss with an authoritative figure such as healthcare providers and their parents, as we discussed. These included topics such as sexual health, but even with peers, young people reported that they were hesitant to discuss any major or personal health concerns as they are afraid that they will be bullied or ostracized. When it came to sexual and reproductive health information provided through schools, we found that studies usually reported on teachers as information sources separately from the school system and school curriculum as an information source. So when it comes to the teachers, we found that young people did not feel comfortable discussing their sexual and reproductive health with school counselors or class teachers, as they were afraid that they would be reported to senior administrative staff and would be discriminated against at school. On the other hand, we found that for some students, the general reproductive health lessons that they received as a part of the school curriculum was where they gained the majority of their knowledge on reproductive health. And so they found it quite important in terms of their knowledge expanding on the topic. That being said, there are many gaps reported in studies about the implementation as well as the content of reproductive health classes. For example, as reproductive health was usually taught through specialist classes to senior high school students, young people who had dropped out of high school early, who lived in rural and estate sectors of Sri Lanka, and who had not yet started their high school education had received none to very little reproductive health education through the formal schooling system. Furthermore, important reproductive health topics such as menstrual health hygiene and pregnancy prevention was not included in the school curriculum, we found. This was because classes were reported to be theory-heavy, focusing primarily on the biological aspects of reproductive health, which were usually taught through content-heavy textbooks. So, out of the 16 studies, 10 collected data on how young people perceived sexual and reproductive health services available for them. In terms of availability, we found that young men felt excluded from sexual and reproductive health services, as most healthcare providers and clinics were only specialized in the reproductive needs of young women. We also found that there were many factors which inhibited from accessibility of youth-friendly sexual and reproductive health services, and these included the costs associated with using such services, the fear of stigma and judgment, the inconvenient opening hours of the clinics, and some embarrassment on behalf of the young people. Finally, when it came to equality, the biggest issue was when young people attended sexual and reproductive health clinics, they felt like the healthcare providers were withholding information from them. Topics which were reported to have been avoided by healthcare providers when discussed or were not brought up to the young people included sexual and reproductive health, sexual health in particular, contraception methods, and pregnancy if the young person was not married. So the systematic review aimed, as we mentioned, to analyze and the existing evidence to understand the sexual and reproductive health information and service needs and preferences of adolescents and young people in Sri Lanka. So overall, one key finding was that young women were more likely to seek out sexual and reproductive health information compared to young men, commonly using informal information sources such as mothers and peers. On the other hand, the fear of judgment, the common practice of withholding sexual and reproductive health information from young people, and a shortage of accessible and inclusive youth-friendly sexual and reproductive health clinics were some major barriers why young men and women experienced when accessing information and services provided by schools or teachers and trained healthcare providers. So what does this mean in terms of recommendations? So there are two parts of the recommendations. Firstly, recommendations made by researchers of the studies included in the systematic review. So these recommendations included how sexual and reproductive health services and information and sources could be improved to better meet the needs of young people in Sri Lanka. And we got this from 15 out of the 16 studies including the review. In summary, there were three key categories which nearly all of these author recommendations fell into. Firstly, many recommendations stress the importance of developing community training programs to improve the sexual and reproductive health knowledge and communication skills of parents, particularly mothers, so that they could provide more accurate advice to their children and especially daughters. Recommendations also called for the close collaboration between key stakeholders for the bottom-up development of information and services to reflect the changing needs and preferences of young people. Particularly, recommendations emphasize the importance of interprofessional training and collaboration between teachers and healthcare providers, both to upskill teachers and expand the school health curriculum. Finally, researchers called for the widespread promotion of formal youth-friendly sexual and reproductive health services and information sources across social media to increase awareness about what is available. So upon increasing awareness, they identified that young people are more likely to access what's available for them and not feel like they're left out from the sexual and reproductive health services and information available in Sri Lanka. So overall, the education of parents and teachers, increased partnership between key stakeholders to develop effective healthcare interventions, and the extensive promotion of available youth-friendly resources are key recommendations on how sexual and reproductive health information sources and services could be improved to better meet the needs of young people in Sri Lanka. When recommendations for future research, we found that future research should focus on the diverse communities to better understand the complexity and nuances of the sexual and reproductive health information and service needs and preferences of young people. This is because we acknowledge that there is no one-size-fits-all prescription to meet these diverse needs. For example, studies need to be conducted with young people who are completing higher education, of vocational training, gender and sexually diverse people, and youth from all different ethnic and religious backgrounds. Only upon understanding the diverse needs could sexual and reproductive health information sources and services truly be improved to better meet the needs of all young people in Sri Lanka. Thank you very much for listening to my presentation, and these are just the references.
Good day for all of you who have joined today for this conference. After many years of trying to catch up with the missed school time due to COVID-19 and economic recession, we are finally almost there after 3 long years, where the academic year will overlap perfectly with the calendar year. And this is the perfect time to reflect what was the impact and what we could have done better in school education during the COVID-19 and the subsequent economic recession. My dear friends, I am here to brief you about our study titled The Impact of COVID-19 on the Dynamics of the Sexual and Reproductive Health Education at Government Schools in Sri Lanka. I am Malit and I am presenting today on behalf of my research team, including Ms. Savitri Gunathilaka and Professor Indral De Silva. The provision of sexual and reproductive health education in Sri Lanka is a crucial long-term investment that shapes the future health and well-being of young people. However, the COVID-19 pandemic significantly disrupted this essential service, posing long-term unprecedented challenges to the delivery of sexual and reproductive health education in state schools. We work on 2 objectives. First, to describe the difficulties encountered in teaching SRH during the COVID-19 pandemic. Secondly, to assess the impact of the pandemic on the provision of the sexual and reproductive health knowledge in the schools. Moving on to the methods, this was a cross-sectional study using snowball technique to recruit teachers. We conducted this research online using a Google form, which was shared via email and social media applications. And this study was conducted in all 3 districts in the Western Province and Galle and Radhapura districts, and these were conveniently selected. On eligibility criteria, participants were recruited if they teach sexual and reproductive health subjects for grades 6 to 11 in government schools for at least 1 year before the data collection. No personally identifiable information was collected. Data was summarized using graphically representations and tables. Associations were tested using Fisher extract. Moving on to the interesting part of my presentation, our study sample consisted of 60 teachers. More than 4 teachers out of 5 were females. The mean age of the teachers were 40 years. And 65% of the teachers were from the mixed schools. And most teachers were from the urban schools. And 3 out of 4 teachers were employed in the schools in the Western Province in Sri Lanka. So shifting our focus to experience, close to half of the teachers were experienced 10 years or less, whereas 3 to 4 teachers had only 10 years or less experience in teaching sexual and reproductive health at schools. During the peak of COVID-19 in 2020, we all had the experience of lockdowns and school closures. Hope you all remember the struggles we had with online teaching, which was a novel experience at that time. However, still, 75% of the SRS teaching was only conducted at classrooms in 2020, and 4 out of 5 teachers expressed difficulties in conducting SRH content online. But more than half of the teachers were actually satisfied with their effort teaching online. Interestingly, 70% believe that lack of sexual and reproductive health inputs due to COVID-19 will have a negative impact on the students in the long term. This table describes the percentage of the SRH syllabus coverage in the year 2020. I would like to draw your attention to the poor coverage of the SRH content in the 2020 academic year, irrespective of the method of content delivery to the students, that is either online or physically at the classrooms. This table compares the SRH delivery to students in grade 6 to 11 in the government schools. As you can observe, there's a significant drop in the syllabus coverage in the year 2020 compared to 2019. Mind you, here we have compared the academic years and not the calendar years. And despite this adjustment, the difference is still significant. In fact, at least 75% of the SRH syllabus were not covered by any of the school teachers from the rural and state sectors, whereas more than 40% of the urban sector teachers achieved it. None of the SRH teachers outside the Western province covered at least 75% of the SRH syllabus. In contrast, 35% of the Western province teachers covered it. In addition, at least 75% coverage of the SRH content in the boys-only schools were only achieved by 1 in 9 teachers. In comparison, 36% of the mixed and as high as 55% of the girls-only schools achieved this mark. And this is one of the quote by a teacher to our question on if you're faced with the difficulties in teaching SRH content online, explain why. So the teacher highlights the difficulty in teaching the sexual and reproductive health content online due to the cultural issues associated with teaching the sexual and reproductive health content at the home environment, as well as the general concern, that is, students were not attending the online sessions during the COVID-19 pandemic. So, looking back our results, we concluded that COVID-19 severely affected the formal SRH teaching at state schools. Not only that, the COVID-19 pandemic has disproportionately affected the delivery of the SRH education in the state schools, particularly those located outside the Western province and in the state and rural sectors. Another major concern that has emerged from this situation is the inadequate delivery of the sexual and reproductive health education to boys. On recommendations, the future strategies to enhance the delivery of the SRH education should focus on improving teacher skills with a particular emphasis on underserved state and rural sectors, as well as the schools outside the Western province. This targeted approach will ensure that all students, regardless of their location or gender, will receive the necessary SRH education. Further, students who did not receive an adequate level of the sexual and reproductive health education from schools due to the COVID-19 pandemic and the economic recession are required to be educated via out-of-school programs. The major limitations of this study are: number one, the sampling technique. Due to the limited resources and difficulties in recruiting SRH teaching staff, because they are limited to 1 or 2 in numbers for most schools, and to recruit 60 teachers would be very, very difficult. Secondly, with the convenient sampling, we ended up with the majority of the teachers representing the urban sector and in the Western province. Thus, we should be careful in generalizing findings. So these are my references, and thank you for listening.
Please raise any questions or any comments during this time.
So you mentioned that you have done a thematic analysis based on the results, but we couldn't see in your presentation. Would you like to share some of the codes that you thought was something new and important that you found in your research? Thank you.
Sorry for that. Because of the time constraints, I could not include everything there, but the statement, the final analysis from the thematic analysis, I actually mentioned there. Some of the codes so that, we recognize what really shaping up our behavior, right? What really shaping up behavior. We never thought media can influence to such an extent. And we never thought that, men are, both men and women are equal, especially in decision making. Now we realize that how we should, deal with our fellow female partners. So those are some of the things that.
This is a very unique finding. Thank you so much for sharing.
Thank you.
And I have one more question, if I can. This is for Dr. Amila Chandrasri. So you said the immediate output was from the students based on the SRH, edutainment was wise. It's about ambition, like they want to become a doctor or lecturer. Why is not based on SRH? That's my question.
Yes, good question. And actually the Rhythm to Life was we discussed about range of topics, as I mentioned before. And though the SRH is the key theme, the entire range of life skills. And for the evaluation, we only included this relevance and acceptance part. To identify the outcomes related to SRH, that we need further studies. We need further evaluation. At the moment that we are planning them, we are going to do a kind of approach them after 3 to 6 months period and do some qualitative analysis by interviewing the counseling teachers. And we are going to review the questions and the issues forwarded to the counseling teacher after this program.
Okay, and I hope that you collect some quality data from the children,
Yes.
how they felt about SRH. I think that would give us more input on what the students need and what they actually grasp from the program. Thank you so much.
Yeah.
And I'm trying to bring up the conversation we had at the plenary session as well. So it is all about school children and then Hate Potha and how sexual and reproductive health is being comprehensive sexual education is being imparted, and also the responsibility of the teacher imparting the knowledge. So I'm just it's not a question, but I'm just I would like the audience to think about how we can integrate what we just discussed, Dr. Amila, and also the other presentation, whether we can put everything together in order to, because textbooks are, I feel, I'm a history lecturer at the Columbia University, and we are trying a lot to kind of revise the history textbook, school textbook, but it is a uphill task, I must say, and it has been, we have tried this over a long period of time just to get get people to think out of Sinhala Buddhist history, but think of other histories that the country that we have. So, however, so I think it is time for us to get out of the textbook thing and try and see whether we can take other forms of, because this generation is not, they don't have that kind of reading ability, or the concentration span is very limited. So in that way, I think edutainment would be a lovely way of intervention, but why don't we mainstream it? That is my suggestion. Yeah.
SRH is not their focus. Reproduction lesson for science is for exam. Health is merely for exam. SRH focus is not there. Like the Dr. Amila's presentation, students, they commented like, this was the best program I ever had. Might be. You have teachers who are rather like 45 years plus age coming to teach for O-level classes. The lesson on SRH or life and health programs, the main focus on EPA. No. In morning sessions, they were focusing on telling that religion and culture is a bias. I would say rather religion and culture is not a bias. None of the religion says, all the religion will say kame hasiri vardava hasirima vardak nisa kame hasirima vardak kiyala I don't see. Kamesu mityachara veramani. Kamesu chara veramani kiyalle mityachara varadi hasirima. Bad practice is wrong. So what we calculate on students is sex is wrong. We say students sex is wrong. That's why I was totally disagree with the morning presentation where they tell you have to be 16 plus to practice. Yes, I agree to practice, but it's not, age limit is not there for educate. From small days you can educate. The first time I saw those books, I don't know whether it's there in the Royal College. First time I saw those books, they tell it's online, they tell it's to purchase to parents. But we are focusing international conferencing the SRH development. They tell they have books. Education is made only in Maharagam. Education is made in Maharagam, but it's barren. They don't give birth to reforms. So I would rather say these things are good, ideas are good, but rather focusing how to make the rhythm of life, focusing techniques to teachers to conduct it. Rather than they will make a group, yes, but financially it will not happen. It will happen 1 or 2 years. But long-term conduct should be there. Until this principle is there, you can have. How about the new principle comes? This director will allow. How about the new director comes? This minister allows. How about the new government comes? No. SRH should be a non-biased, independent program to be conducted in all other four schools. Basically, from year 1 to 11. In normal schools, we see most outside 1 to 11 is very common. So give importance of reproductive.
Fully agree with you. I think there should be, to me, we know what happened to this Hate Potha business, and it went to parliament, and who opposed it. And I mean, they opposed because of they have some vested, some conflict of interest with that. Those are the institutions where the abuse is rampant. So anyway, I think there should be a good leadership, political leadership at the highest level, because it's a political decision as well. So usually, if a government take a decision, then the opposition will start attacking. And so I think, I hope at least the new government will take it seriously with a group of real professional advisors, and they let it happen rather than wait till the end of their term and trying to introduce something new, and then they will, isn't it? So let's hope for the best, and this is a very good opportunity to start this conversation. Any other comments, please? We have about 5 more minutes.
We have a very good, very well established school health program in Sri Lanka. So it is expected that the education and health ministries work together. But the problem is, like many people mentioned, there is no real collaboration. The education department wants to educate. The health, we have other intentions. Very recently, a zonal education director he accused that the health is invading the school system. in a HIV prevention program, when the Northwestern Province governor is there, a zonal education director did that comment. So he said that with various topics we are trying to invade the schools, and they will not have time to teach. So he was mentioning about the various health programs. So like there were recommendations that more programs should be done in the schools to cover up the losses done by the COVID. But how can we do those things with that type of attitude?
Attitudes. Yeah, I also fully agree. Actually, it has to be internalized into the education system. What happens is, usually a MOH or a doctor goes to the school and is doing these lectures, which cannot be, a few doctors cannot cover the entire educational system. So it has to be internalized. So doctors can get involved at the initial stage of, developing curriculum or whatever. But after that, it should be internalized and it should run.
That we are trying to start is to develop a joint team between the education and health officials in the southern province, and already we had 2 meetings to agree upon a common plan for the programs doing in schools, because we realized that many parties are coming and doing programs in schools. Health, police, recently the prison department is doing a program, these doing programs. So we got all people to one forum, and then we are discussing to have a common agenda, common timetable throughout the year to cover all the grades and to cover as much as topics. So both parties initially agreed to the concept, but it is very difficult. So at the moment we are trying to give some example from the southern province.
We had a very informative session. It ranged from the that predictors, patterns of the contraception, consent manage, and the interventions on SRH, and also barriers in the education system. I think this added for the gap in the information, and the comments also should be forwarded to the relevant ministries, and appreciate the comments as well. All the presenters did a very marvelous job, and my co-chair also. So thank you all and the audience for active engagement. So we will conclude the session. Thank you for the presenters, co-chair, audience, and all.
Thank you very much, Doctor. So we would like to conclude the session by, first of all, thanking the 2 chairs of this session, Dr. Ariyaratne and Dr. Chirantika, for the marvelous job that you did today, and also to all the 6 presenters of this session, the 6 researchers that were shared with you. I think they would add a lot to the sector of SRHR. So now we would head on to the awarding of the certificates. I invite Dr. Chirantika and Dr. Ariyaratne up to the stage to hand over the certificates. So to the 2 presenters who were presented online would receive their certificates as e-certificates. Meanwhile, I would like to first invite Dr. Manas Pradhan. Dr. Manoj Fernando. Dr. Radhakrishnan. And Dr. Amila Chandrasiri.